membuatkan
Sir, we are live now.
Okay. So, good evening, respected doctor. Now, I invite my medical advisor, Dr. Aditi, to just start the proceeding. Yes, Dr. Aditi, please.
Good evening to all the panelists, all the doctors, to the webinar on the non-surgical management in osteoarthritic joints. I would like to welcome you all on behalf of McLeod's and Osteva. For today's session, we have Dr. A.K. Pal as our moderator. Next slide, please. Sir is MBBS, MS Ortho and DNB Ortho. Sir has multiple publications, around 42 international and national publications in index journals. And Sir is also author of a book called An Atlas of Orthopedic Surgery. Sir is also selected as one of the inspiring orthopedics of India of the 2019 by Economic Times. Sir is currently working as professor and head of department in orthopedics and traumatology in IPGMR and SSK Medical College, Kolkata. Sir is also AM Mehta Gold Medal 2002, and also part of, he has also presented many posters and papers in multiple conferences. Sir is also a national CME lecturer and is immediate past editor of Journal of West Bengal Orthopedic Association, and is also a reviewer of Indian Journal of Orthopedics. With this, I would like to welcome Sir in our session, and would like to hand over the session to Dr. A.K. Pal, sir. Over to you, sir.
Thank you. Thank you. Hello. Thank you, everybody. So we have gathered for a very, very valuable evening to be dedicated for a very important topics. And for this, we have actually found that very eminent personalities of different corners of the country. And Professor Janjit Kumar Barua, he is a renowned professor and head. He's just retired in the Dibrugarh, Assam, in the Department of Orthopedics. He's undergraduate teacher since 1990 and the postgraduate teacher since 1995. It is an ardent academician. He's upgraded the Department of Orthopedics at Assam Medical College of national repute, imbibing his recent advances in technologies. He has much more publications in journal, national and international journals of 33. He has numerous papers presented in journal, national and international conferences. It was more than 70. He is now is a faculty of various journal, national and international conferences since 1994, and now is an executive committee member of IOA Assami, India, and now he's becoming secretary and president of NEROSA. So welcome, sir. We'll be enriched to your expertise and the knowledge. Next, please. I'm also have a proud and privilege to welcome Dr. Tanmay Mahanti. He is Associate Professor in Department of Orthopedics in SCB Medical College, Cuttack. He is MBBS in 1978 and MS in Orthopedic Surgery in 1984 from Utkal University. He is well-known at national level for developing indigenous external fixators, mostly using the bicycle parts. And in 2014, he was awarded as a Shushrut Gold Medal Award by the Indian Orthopedic Association for his innovation of the new plate for hip surgery. He is honorary secretary of the Odisha Orthopedic Association for 5 years. He is a past president of Odisha Orthopedic Association. Now he is presently president of Odisha Orthopedic Association. So also, he is also associated with the academics and the participants in seminars and teaching courses for a long period. We are very much proud and privileged to welcome you, sir. Then again, I'm very much proud and privileged to welcome Dr. Amulya Kumar Singh. He is a very renowned and very versatile personality. He is graduated at Armed Forces Medical College, Pune in 1988. He is a postgraduate in orthopedics, PMCH, and the hospital management, LNMI in Patna. He has numerous degrees, including the MCH in orthopedics and PhD in orthopedics from LNMI, Darbhanga. So he is a postgraduate certification in rheumatology also from the Johns Hopkins University. At present, he is acting as a consultant orthopedic surgeon and the medical director of the Akshat Shiva Sadan, Jaipur, Patna. He is a former president of Central Zone of Orthopedic Association in 2012 to 2013, is a former secretary of the Bihar Orthopedic Association. He has presented the scientific papers at different international forums as guest speaker along with the national level. He is a special interest in traumatology, osteoporosis, pain management. He is awarded by the Economic Times as the Inspiring Orthopedic Surgeon of India in 2019 in Delhi on the eve of Doctor's Day. We are proud and privileged and very much honored to have you, sir. So welcome you to have your excellence. Thank you. Thank you. So at the outset, I'm handing over the mic to the Dr. Mr. Taggi for starting the program. He will discuss the different flows of the program, and after that, we'll start our this discussion. Over to Dr. Taggi.
Yes. So I think the flow of the program is like that. Dr. Barwa sir has to give his talk the first. So now I request Barwa sir to uh, take his talk. Barwa sir, I think Barwa sir has not joined yet.
Yes, sir.
Uh, so Mohanji sir, so now I request, I think I will speak to Barwa sir. So now I request uh, Mohanji sir to just make the slide changes and take his talk. Sir, hand it over to you, sir.
I can wait until Dr. Barwa comes. What we can do is, of course, I'll be welcoming all the delegates who are present there. Basically, it was a plan that we should discuss something about osteoarthritis and mostly the non-surgical part of it. And as you know, for the COVID, we are at home, most of us. So most of the time we are busy in webinars. At least we talk to each other. We have been already explained about our plans that in the initial phase, Dr. Barwa would have been talking about the non-surgical part of osteoarthritis, which he wanted to describe mostly about the flexor deformity and initial problems with a joint arthritis due to degenerative arthritis conditions and how you are going to handle it. He has done a lot of work on that, so he wanted to share with us. And Dr. Singh will be talking about the medical management, mostly with the medications. And here basically, what we have discussed today evening, that we should come together and discuss something about the non-surgical possibilities of anything new which is coming up. So this is a forum where mostly experienced orthopedic surgeons are available, and people who are not orthopedic surgeons, now they are quite aware about the management of degenerative osteoarthritis. And if there is any physician amongst us, obviously he thinks about more about the non-degenerative conditions like diseases like rheumatoid and others, which normally we refer cases to them until it comes for a surgery. So when we are talking about the non-surgical part of it, it was discussed that Dr. Barwa will be talking something that initially how the patient's progress of the osteoarthritis occurs. So as I'm the second speaker, but I'm taking over now. So I'll just try to tell you a few things, which I think it has come to your mind when you treat a case of osteoarthritis. So let me go to and start my talk. In the meantime, if Dr. Barwa comes in, I think I can stop the talk and ask Dr. Barwa to continue his talk, or I'll continue that and finish. I don't think you will feel that it was haphazard, because I'll try to avoid, because I know what he was planning to tell, I'll try to avoid overlapping of the things. So let me share my screen. And in case you have any doubt, we have discussed that after three of us, we finish the talk, the questions will be discussed. And then Dr. Pal will be taking over with few cases, clinical cases, so that we can discuss what is best for the patient. Then I think the whole discussion of the evening will be fruitful. So let me start my sharing the screen now. I think you can see my screen. Thank you. So this is what I was trying to tell. Dr. Borwa suggested that he will be discussing about the initial description of a case, how it presents. That means, as you know, any case having a degenerative osteoarthritis, mostly if you see a person around 40 having pain in the knee joints, and normally they come with the dominant side complications first. That means the right side, mostly the persons will tell that I am having pain. And as you examine the patient, you find a tenderness mostly in the joint line on the medial aspect. And then gradually the whole joint gets affected. In the initial phase, when you examine the patient, you find a medial joint line tenderness, and sometimes you may find a little bit of effusion. At that moment, you think that you have to exclude other conditions, so that finally you are dealing with a case of degenerative osteoarthritis. So that is what, in the initial phase, if you take an X-ray, you may not find any radiographic features. But if you wait for some days, and then the patient comes back with pain, possibly when you take an X-ray, suddenly you find the medial side joint line has reduced. This is a common thing which we try to show it to the patient and tell him, see, the cartilage has been worn out now. That is why the femur and the tibia on the medial aspect, they are mostly meeting each other. That means the joint space has reduced, and this is how a degenerative joint disease will be continuing. And in future, in case this continues, possibly the lateral aspect of the joint will be affected, maybe the patellofemoral joint will be affected, and overall, the person will be having deformity in the joint and sometimes too much of pain, may even resort to a surgery like total knee joint replacement. And it was seen that when the patient is having a little flexion deformity, if you take an EP view of the knee joint, as you know, normally the X-ray of the lower end of the femur overlaps the upper end of tibia on the medial aspect more. And when you see that is covering, that means indirectly in the X-ray you find that there is a reduction of joint space on the medial aspect, even if there is no reduction in the joint space. So our main aim is to keep the leg straight so that it will be easier to take an X-ray. And then when the knee is completely straight, we find that the medial side of the femoral condyle completely rests on the medial side of the tibial condyle. That means in a normal way we move around. The moment the person keeps the knee flexed and then tries to walk, the posterior part of the medial condyle gets compressed over this. And slowly, when the cartilage is affected, the person gets more pain. And gradually the person tries to keep the knee in flexion. And sometimes we get a fixed flexion deformity, maybe 10 degree or 12 degree in these conditions. And when the patient has got a 10-15 degree of fixed flexion deformity in the knee, he gets a habit of walking with a flexion. And when he tries to straighten the knee, there is pain. So sometimes we think, why not just unload the joint? There are people who have tried to unload the joint and try to find whether they can get any help from that or not. So I try to get into certain things like surgeries which can be done, or non-surgical part when it can be done. In the initial phase, when you get a person maybe around age of 40 having pain, mostly the person comes with a pain in the left side or right side. Here I find the patient is having pain more on the left side and little bit also on the right side. If you just look at this patient from a distance, you can feel that possibly the varus which has come up on the left side is more. When you take a wet-bearing X-ray, this is what you will find. What we try to do in this case is, we try to tell the patient what you should do, what you should not do. And this is the basis how we handle a case of degenerative joint arthritis in a young man, maybe around 40 or 50. So we tell them, don't squat on the ground. Never sit on the ground, because when you try to get up or from squatting position, you try to get up, there is a lot of stress on your knee joint. So avoid it. Use the commode. Never sit on an Indian style of latrine. But sometimes even we find that if the commode is a little low height, when the patient tries to get up, he gets pain, because that is the site where a lot of pressure comes on the knee joint. That is why sometimes we suggest, even after a knee joint replacement, to increase the height of the commode for betterment of the patient. Of course, we always tell them about stairs. If you are using the stairs frequently, then try to use the rails on the stairs so that you can take some support there. Now, what about the stick? As you know, you tell them, yes, if you are having pain on the right knee, try to use the stick on the right hand. But most of these joints in the knee, when it gets affected, you get bilateral affection, and there a stick will not help. And if the patient really needs help, normally they go for a walker. Just a minute. Hello. So, in this condition, we suggest always the patient to take a quadriceps exercise. Why? That you know that when you are trying to tell the patient to do a static quadriceps exercise all the time, you find the leg becomes slowly straight. Instead of having a fixed flexion deformity, the knee becomes straight. And second, what we think is that the main muscle, that quadriceps, which handles the knee, must be always perfect. That is why from day one, we tell the patient to strengthen the quadriceps as far as possible, and possibly we never tell them to stop that static exercise. And it becomes a habit of the patient. Whenever he remembers about the knee pain, he starts doing the quadriceps exercise. So if you go back to the X-ray and try to explain to the patient what has happened, you look at the medial joint side. You can easily see there is a gross change in the joint. That is, the degenerative changes are seen, and also you find that on the medial aspect there is a joint space is reduced, and obviously on the lateral aspect you find a lot of gap due to ligament laxity you can consider, and it is going into a varus. So if you compare these both, you find that left side is having more varus. So obviously the person has come with pain on the left side, and you explain him that possibly your left knee joint is affected more. Maybe one day you will be requiring any surgery for that. Right now we are going for all conservative methods, whatever is available. Now this is a very abnormal thing, because when people come back to us with pain, recurrent pain in the joint, you will find that they will be coming with a kneecap like that, and they ask several times, doctor, should I continue having a kneecap? But I don't think a kneecap really helps a patient, because that never supports a ligament or a joint. So what it can do, it will give a soothing effect that somebody is there just telling you to stay like that in that position. And when a tight kneecap is there, sometimes the patients get a little bit of edema in them. I see Dr. Borua now. Dr. Borua,
Yeah.
but I think that if you start your talk, it will be better, because I did not want my friends to be idle there. I started my talk. So I think you can start your talk now. After you finish, I will go back to my talk. That will be nice. You can share your screen and start. I am stopping the sharing of the screen.
So you have to unmute yourself. Okay, you
Yes.
will have to come out.
No. I have stopped sharing. You can start now.
Okay.
এটা জ্বালাতে বলতো না, এটা লজ্জাটা খুলতে বলবো।
Yeah, I'm trying to get my screen. Sharing with files and folders. Full disk access. Files and folders.
Sir, do you want I can share from my side, sir?
Yeah, let me just a moment.
Okay, sir.
Just a moment. Hello.
Yes, sir.
Okay, please go ahead and take my slides.
Sure, sir. Sure.
I think you should start from the first one.
Yes. Yes.
Yeah. Okay, I'm sorry. Actually, I have been here on the table for 5:45. Somehow I missed the bus by 15 minutes. I'm sorry, I kept everyone waiting for me. Good evening, my dear friends. I'll try to tell you something which we have learned recently. Some concepts, a little bit of a hypothesis, you can say, because of our little bit of research we have done in the osteoarthritis, in early osteoarthritis of the knee joint. Next, please. Next. As you all know that osteoarthritis of the knee joint is a degenerative disease, primarily involve the articular cartilage. And if we look into the anatomy and physiology of the articular cartilage, it is an avascular aneural structure as devoid of lymphatics. And therefore, if there is a damage in the articular cartilage, the repair becomes slow. And very interestingly, the chondroitin sulfate, which is a part of the architecture of the cartilage, it is replaced by calcium if there is a reparative process, thereby reducing the elasticity of the cartilage. Next, please. Now, let us come to the point. With the advancing age, there's a muscle weakness as a part of sarcopenia, as well as diminished proprioception. So these involve not only the whole body, also as a part of that, the knee joint is also involved. So muscles around the knee joint they become weak, as well as there's a diminished proprioception for the knee joint. Now, because of these two factors, they initiate and sustain the degenerative process involving the articular cartilage. Next, please. Now, what was the background? Next. There's a publication by ESD et al. In 2014 when they documented one operation called proximal fibular osteotomy in managing early osteoarthritis of the knee joint. And they have shown early increase in medial joint space and reduction of pain following surgery. But then, because of these two facts, what led to when you just take out a chunk of fibula and you get increase in medial joint space and reduction of pain? What is the concept behind? What is the reason behind? Then we looked into their papers, not only their papers, but into several papers, but we could not find any satisfactory reasoning for the same. Next, please. Next. So, no, just one slide before. No. Go back. Yeah, yes. So we started thinking in a different way, not by going by their hypothesis. Next, please. We all know that whenever there is an early inflammation, there's a mild flexion. This is the position of each in any joint. Next, please. And especially in the knee joint, when the knee goes into flexion, there's a loss of screw home phenomena. And that leads to unlocking of the knee. And because of the unlocking of the knee, the walking for long becomes very tiresome. When the knee is flexed, as Mahanti has said, the non-weight bearing posterior part of the medial femoral condyle starts bearing the weight. Now, what is the fallout of this phenomenon? Next, please. Flexion deformity. So, more posterior portion of the cartilage of the medial femoral condyle comes to play and starts bearing weight because of the flexion. And this part of the cartilage is thinner as compared to the cartilage in the anterior part, rather the weight-bearing part of the femoral condyle. So a non-weight bearing, thinner cartilage is forced into weight bearing because of the flexion deformity. And then this is the area where there is a beginning of the wear as a first stage in the posterior part of the femoral condyles. Next, please. Especially on the medial side, which is hanging down a little bit. So the thinner posterior part of the middle femoral condyle articular cartilage. Now, I think this X-ray is not visible. Can you just take out, because this picture is not coming out nicely. there is some profiles on the right side. Hello, hear me? Hello, hello.
Yes, sir. Yes, sir.
Because the screen is it's blocked by the profile on the right side of the screen.
I am
Like
able
my
to
face.
see. I am able to see very clearly, Doctor, sir. It will be visible to you only, but for me it is coming in the full slide very well.
But then you take out, because it will be difficult for me to continue. You take out all this on the right side of my screen. Only allow the presentation to stay.
So it is not possible. It is not possible. Actually, then you have to make, don't go for PowerPoint presentation. Just go normal presentation as such. Don't magnify the screen. You have to cut down, minimize the screen then.
You can minimize, try to minimize the screen because it's not in my hands. No. Come to my presentation. Please come to my presentation. Yes. Okay. All right. So this thinner posterior part of the medial femoral condyle is thin, and because of the flexion, this comes as a profile in the X-ray. And this is exactly the reductional joint space, but it is not the reductional joint space because of the flexion attitude, the thinned out or thinner articular cartilage on the posterior side comes into the X-ray view. That is why it gives an idea that medial joint space is reduced. So this is because of the flexion contraction. Next, please. Now, when you correct the flexion deformity, it restores the screw home movement. Then that leads to better locking for ambulation and relieves the posterior pathological eroded portion of the medial femoral condyle from weight bearing. So the pain subsides. If you can see my slides, you can see my slides in the screen, right? Full of it. Okay. So you can see that we started doing this research. We also started proximal fibular osteotomy, and we are getting as a thesis of my postgraduate student. Then after that, we also continued the research, and we had to think why these things is happening. That reduction of joint space after surgery, the space comes back so quickly. So this was a hypothesis that because of the flexion contracture or attitude at the knee joint, the thinner articular cartilage comes into profile in the X-ray and gives a false impression of reduction of the joint space. So secondly, next please, and you can see that after 6 months we had an improved. Now, what are the lesson we learned from this experience? In osteoarthritis of the knee joint, before that, I wanted to tell you another point. One is that because of the flexion, why the flexion is corrected after doing a proximal fibular osteotomy? Because the posterior lateral capsule and other soft tissue structures, they become relaxed. When they become relaxed, the flexion is automatically corrected. So this is our hypothesis, and this is the concept that has been immersed in our mindset after doing so many proximal fibular osteotomy. So correction, what we have learned is that this is called a backward learning. If somebody of you have attended the AO courses, AO faculty courses, AO chairman's courses, then you will learn one thing, that this is called a backward learning. First, you project the final what you are going to achieve at the final stage of your treatment, and then you come back from that step by step to modulate your treatment protocol. So this is what we have done in this case. If you correct the flexion, then in early osteoarthritis, probably you are going to have a better result. It is the effective way to arrest the pathology or delay the progression. So whenever you are taking up any physiotherapy in early, which is in paramount because of improving the pain and other things, the physiotherapy is an integral part. So when you are doing this, the physiotherapy, you need to take stock of the posterolateral structures. They must be stretched out to correct the flexion deformity. Next, please. Next. So you try to correct the flexion. Now, how you can correct the flexion in an early osteoarthritis? No, you go one slide early. Before that, yes. Two things I have told you. One is that muscle is very, very important. You can take help of your weight of the muscles and strength of your muscles to correct all these flexion deformities. You can just see very simple exercises that can be taken up. You put something here and try to extend the knee joint. You take something under the ankle, you try to press the knee and you get a correction of flexion of your knee joint. Then this is a passive extension of the knee joint. Very gently, the physiotherapist will try to extend the knee joint with the permission of the patient. What is happening? Hello. My Zoom has gone. Can you hear me?
Yes, sir.
But
we
my
are able
slides
to.
are.
We
But
are
my
able to
slides
see.
are. Yeah. But my slides are not there. I don't know.
Oh, we are able to see.
You can see, but I can't see
Yes.
it.
Oh,
Anyway.
sorry. Try to reconnect, sir.
I can't see it. So what to do? Just a moment.
Sir, left slide. You are in if you are in mobile, you can left slide yourself.
Just a moment. Just a moment. What I'll do is I'll do everything minimize. I'll minimize this. I'll
It is
minimize
on
this.
laptop or computer.
Yeah. I'm in a laptop. I'll just do it now. Whatever you say. You can see
Because
my
we are,
slides, right?
yeah.
You can see.
Yes, sir.
Yes,
Okay.
sir. We are able to see, sir.
Oh, that's fine. Then easy for me. Just a moment. Give me some. So we were. Now, so how to correct the flexion? One is the suitable physical therapy to reduce the inflammation and effusion. You can see my slides, right? So you can see my slides.
Yes, sir.
Yes.
Okay. So basic, very simple physiotherapy, physical therapy things are there, like wax bath or heating pad or whatever it is. You try to give it to the patient so that pain becomes a little less, and also some drugs. I think that will be highlighted by seeing NSAIDs, coccyps, disease modifying osteoarthritic drugs. You can give it. This will help us to reduce the pain. At the same time, it is very important to start the dedicated exercises to correct the flexion deformity. So these are the very simple 4 types of exercises I have shown to you, but there is variety of it. Once the patient is handed over to the physiotherapist, he will try to correct the flexion deformity in different ways without harming the patient. Now, dedicated basis. Once you try to correct all these flexion deformities, what do? You try to maintain that. This is very important. So at the initial stage, you try to put a hinge brace. And once you put a hinge brace, gradually as you keep on correcting the flexion deformity, you can have a fully extended knee, and then a hard brace like this can be worn by the patient. Now, when the flexion is corrected, one should start strengthening exercise of the quadriceps and the hamstring. This is very important because it's a part of the whole osteoarthritis is a result of the weakness of the muscles because of general sarcopenia, especially in elderly. So it is very important to strengthen the quadriceps, the hamstrings, and the calf muscles along with that, so that the power gain back. Very simple exercises. I'm just trying to tell you. On the left hand side at the top, you can see that the knee is, the patient is trying to extend the knee. But here, one very important point is that the foot and the ankles should be extended fully, so that there is a complete static contraction of the quadriceps, the hamstring, as well as the calf muscles. This is very important. You hold it for a few seconds and repeat it again. Then comes your straight leg rising with the ankle, the knee completely straight and the ankle in forced dorsiflexion, so that the hamstrings, the quadriceps, and the calf muscles act statically at the same time against the gravity. Then the hamstring curls, as you can see, the gentleman holding the chair is curling the leg to increase the muscle strength in the hamstrings. Now, as I told you, that proprioception gets reduced as the person ages. Some people say that that proprioception cannot be brought back by exercises, but there are schools of different schools who are advocate that why not a balancing exercise is a paramount. So it's just a simple, very simple balancing exercises. As you go to the right top of my pictures, you can see that standing one leg with the arm up, or without, just come to the picture just below it on the right side, arms down, you can do it, one leg, standing in one leg. This will take care of your extending the knee as well as keeping it locked. And so you get a good proprioceptive action, because balancing in one leg is very, very important. So middle figure at the up, you can see that with the help of a chair, you can raise the leg, or you can left side, in the top left side, you can extend the hip as well, so that you get a good proprioceptive influence on the knee joint to trigger your proprioception. Similarly, you come down, you can abduct and adduct your leg standing in one foot. And this is another very important asana, Brikshasana. This is little difficult for the elderly, but if they start doing this, the foot can be put on the leg. To be very precise, on the lower part of the leg, you can start with that. If you cannot put it, the heel cannot be put at your crotch. So you can ask the patient, somebody can, the physiotherapist can gently instruct them the correct way of doing this. This is very, very important. So these are a few tips how to improve your proprioception. So this is a very small presentation I have prepared with my understanding of the early osteoarthritis, how to take care of it. So the message is that correction of flexion is very important at the beginning, not only at the beginning, but later part also. But because in the later part, there is a conglomeration of other factors that come in. So in the early part, if we can catch it at the inflammatory stages of the osteoarthritis, one should always try to correct the flexion by dedicated exercises, braces, and drugs. And once you correct this deformity, you sustain it by rebuilding the muscle strength around the knee joint, and then improving the proprioception to give a holistic management of the early osteoarthritis of the knee joint. Thank you for your patient hearing. I'm through.
I think Dr. Barua has finished the talk.
Yes,
Now,
yes.
let me share the screen, and I just continue without overlapping whatever he has told. I was up to this. I was talking, I think my friends remember that sometimes even a certain thought, why not completely unload the joint? Here you can see two pins have been passed into the lower femur, and here four sans pins in the upper tibia, and distraction has been given. Where do we expect zero load on the joints? I don't think any of us have ever thought that completely making the joint distracted, it will get rest and the problem in the knee joint will be solved. So this type of study has been done where about 2 to 3 weeks distraction was given. Possibly it was helping in the damages done in the degenerative condition has improved a little. Then the patient is given movement of the joint, that is flexion, extension, everything. And these type of tests or study were mostly discontinued because of the pin tract infection and cumbersome procedure. So as Elizarov method was there, that we think that regeneration will occur if we distract something. Maybe the idea had come from there, and this type of methods were tried in certain areas. And finally, these, as far as you know from the literature, this type of tests have stopped. Now, the easy way, any orthopedic surgeon will look at the knee. He will think that why not I put a plaster and just like a waist correction, I try to move so that we will get a valgus movement so that the medial joint line will be completely without any pressure. So anybody will think that why not I make a hinged knee brace where I'll press it like this. And as you know, a lot of types of braces are available. And sometimes the patients ask the orthopedic surgeon or the doctor treating them that, doctor, can I use such braces or not? So I thought of going into the literature to see what they have done. And finally, what we see here is mostly a double hinge is not accepted by the patient. And when a single hinge is given, as I told you, that on the medial aspect, it has to open up. So on the lateral aspect, the hinge has to press open so that you can get a 3-point fixation. That is why people started making varieties of braces. And this is a brace which was tried in Canada, and a lot of biomagnetic study was done there. You can see it is double hinged, but they tried to see whether by just giving stresses on this brace here and below, and then on the center, on the lateral aspect, so that finally what you see, there will be zero load on the medial aspect. That means the pressure over the cartilage will be less, and maybe there will be some increased load on the lateral aspect. So it comes to a orthopedic surgeon's mind or a physician that possibly the lateral side will be affected more. So types of braces, we cannot completely rely, but when the patient is avoiding a surgery like a total knee joint replacement, if you are telling them that possibly by using a brace you can get relief in the joint pain, they try to use it. And when we try to give them such a brace, we have to see whether really there is no increased load on the lateral aspect or some load is there which is acceptable. Now let us think like this. A person at the age of 50 is suffering for degenerative joint arthritis and mostly pain in the medial aspect for last 50 years. So last 50 years, the person was bearing the stress on the medial aspect. Another 30 years, if he is going to survive, and somehow we transfer this load to the lateral aspect, it can easily take up. Maybe for that reason, we thought that why not do something by which the weight will be transmitted to the lateral aspect instead of medial. And there came several methods of testing it. And finally, people suggested that if you can put a brace like this, maybe double or single hinge, and when you try to give a pressure on the lateral side, and then you try to see what is happening on the medial side. Lot of tests have been done, but none of them say whether the patient is getting a relief by that or it is only a psychological thing because such a big brace is given to the patient. So finally, the patient will not try to have a pressure over the medial lateral joint line so much. That is why what we try to do is that we try to put some lever-like things, that is soft levers like this, and the braces look like this. These are normally known as knee unloaders and sometimes available in the net. And I have seen a lot of my patients without any prescription, they buy it and they use it. For the left and right, obviously it is different. So most of them buy two for the left and right and they start. And when you are bending the knee, these straps become loose. So there is no problem. But when the patient keeps the knee straight, at that moment this becomes stuck and you get the valgus force what you wanted to do. And sometimes people try to raise the heel, as we were doing, raising the heel for varus or valgus in small kids. When growing up kids having rickets or anything, even polio, we were trying to give this type of raised shoes and other things. Now, so if we give for a genubharam deformity, which is coming up due to osteoarthritis, we can put a outer side heel, which is like slightly higher, so that somehow the knee will go into a valgus. So these are all, because how many hours the patient is wearing a shoe in the house, or a person going to his job maximum 8 hours, and out of that another 6 or 7 hours is moving around without this type of shoe. So finally it does not help, and patients finally feel that we do not get any help from this. So the studies have been done, same thing, by increasing the sole height on the lateral aspect to see whether the same effect is coming or not. And this same effect, as you orthopedic surgeons, all of you know, that you can do a valgus osteotomy at the upper tibia. By that high tibial osteotomy, what we call, we can get this effect. And it is forever. It is not for a day or two. So without using such splints or soles, you can get a permanent thing by which the pressure on the medial aspect goes to the lateral, and that stays for a long time. Maybe another 30 years the person has to manage. Now I go back to the X-ray what I had shown you before. The right side, the left side, the patient is having severe pain. And you can see the changes of osteoarthritis, and obviously it comes to your mind that if I do a osteotomy here, I can get the effect what I want. This is what I call a knee preservation surgery. Yes, it is a surgery because we are putting pins here. In the upper part, we are putting a pin. This is the alignment of the tibia now. We want to change the alignment by putting, slowly we are trying to open this. So it is a corticotomy which is done, and we are putting external fixator here, and slowly it is becoming straight. You can use a plate, or slowly you can use this type of deformity correction, or getting into a valgus by putting an external fixator. And finally, what we wanted to achieve, the alignment of the tibia or the femur, has been achieved. This is a surgery. Yes, I understand it is a surgery, but a little bit of anesthesia is enough. The complication of such surgeries are very less. That is what I want to show you. Now, I am not trying to tell details about the method, but you see the 40-year-old man who was having the deformity or varus deformity on the left side has been given this fixator, and slowly it has become straight. And you can see the patient does not have much problem, and he is accepting it. And after that, when we try to take a weight-bearing X-ray, we see what the change has occurred. You can see the medial joint line. Here you can see there is some gap. That means the cartilage possibly is coming up, but the patient leg is straight, and the patient somehow feels better. So maybe we think that the other knee, when he comes with pain, maybe he will opt for this surgery. So this surgery, I am repeating that though it is a surgery, I consider that this can be taken as a very minor thing, what we call a non-surgical treatment of knee joint. That is why when I talked to Dr. Pal, he told, yes, you can talk about the high tibial osteotomy a little bit so that we can discuss about it. Now suppose a lady, this lady only 38 years and having a varus deformity with severe pain in the knee comes to you. Obviously, you look at the weight-bearing X-ray, still you see on the left side, there is a little bit of decrease in joint space, but on right side, it is too much. So here, the same thing. If we think of doing some palliative surgery, you can consider. So then we try to take a weight-bearing X-ray, the lines. You see the axis of the line is not passing through the center of the knee, come much medial. Now we have to achieve that this line will pass through the middle of the knee. For that, this future axis to breadth, we have to do the surgery by putting this external fixator and doing the corticotomy and slowly straightening it. So this is controlled straightening, so that finally the new axis line is passing through the center of the knee. And finally, when you look at the lady, you see both the legs nearly look same. You can consider this is little more valgus. To be safe, we have kept it. This is the right side today she has come. Maybe this joint, degenerative joint, will also come up on the left side later, and finally she will require another surgery on this side, maybe a valgus osteotomy or osteo, what I tell. So recently it has been seen that some people, instead of going for a total knee replacement, they opt for some procedures which are also called non-surgical methods, because the arthroscopists normally tell it is a very minor method. They do a arthroscopic debridement, and sometimes they do microfracture there, sometimes they do trimeniscal transplantation even. But in a malaligned subjects, this newly implanted tissue always goes for a overload, mechanical overload, and they fail. That is why sometimes they suggest that osteo should be done. High tibial osteotomy should be done along with, because limb malalignment is a contraindication to this type of cartilage restoration procedures. And when we are putting this fixator, not only in the epi view, what we see, on the lateral view, if you see, you can see the tibial slope. As you know, sometimes the ACL, the patients having ACL tear, they have a, when we examine these patients, we find that the slope has been little more. And to avoid this, we try to sometimes do this correction while doing this high tibial osteotomy. These are the things we have to consider when we put it, when explaining to the patient a small incision for the corticotomy, few scars, what we get for the pins. If the patient accepts this, that this is not a major surgery, sometimes they can get a trouble-free period for about 20-30 years. Maybe they will never require a total knee replacement. So when we are talking about arthroscopic debridement as a somehow we call a non-surgical method, high tibial osteotomy should be included in those type of selected cases. So that now what I went into the literature to see whether anybody has seen the results of high tibial osteotomy, whether this cartilage is regenerating or not. One study by some Chinese people was there in 2013 in Arthroscopy Journal. They did a second look into the arthroscopic findings after open wedge high tibial osteotomy, focusing on the posterior root tears of the medial meniscus. So when they were treating the posterior root tears of the medial meniscus, they had done a arthroscopy. At that moment, whatever they had done in the joint, they also saw all the areas where the cartilage has been damaged. And these patients, when they had done the high tibial osteotomy, later they did a second look to see what has happened. And they found that these type of meniscus, they healed much better when high tibial osteotomy has been done. Not only that, they also found certain areas which were little more damaged due to the degeneration have improved. That means, I think this type of papers finally will tell us that yes, high tibial osteotomy should be accepted, and maybe we consider as a non-surgical method because the level of evidence is level 4. We have to accept it. So now, when we look into the patient's arthritic condition, we try to explain them stage 1, 2, 3, 4. I'm not going into detail about it because we all orthopedic surgeons, we explain to the patient stage 1 and 2 are quite early. Stage 3 and 4, I don't think anybody will think that I'll go for anything else. This is a slide which has been borrowed from one of my friends. He did surgery for this lady. Obviously, you have to, nobody will think of non-surgical methods here. And finally, what you achieve with bilateral knee replacement, at least the lady can be straight knees and can walk around. Here, I'll never think of a non-surgical method, maybe high tibial osteotomy. But in stage 1 and 2, I'll think that high tibial osteotomy will help. Not only that, knee, when we are thinking about the knee replacement, we never think in 1 and 2. But in stage 3 and 4, we should go for total knee replacement. We should not think of anything else. Now, what is the benefit of this knee preservation method? I consider this is a method. I'm not repeating that it is a surgery because the advantages over the knee replacement is that no restriction of activity. And there is no risk of infection because the knee joint has not been opened at all. No violation of patellofemoral joint, and preservation of the bone stock for the future knee replacement is there in case it is required. So the contraindications I am not going into detail because you know, if the patient is having inflammatory arthritis, it is a no-no for any type of such surgeries. But involvement of the lateral compartment will never help you in this type of surgery. And if the patellofemoral arthrosis is there, obviously we pinpoint our treatment there. And finally, if the pain is not consistent with the clinical examination, blindly we go for a high tibial osteotomy. Finally, we fail. So when we fail, we have to think that we come back, as Dr. Barua says, we try to find out what was the fault, why is the patient still having a pain. Then we think, will it help? Now, the moment you look at the slide, you know, the smiling man, Dr. Ranabat, he popularized this surgery in India because he operated lot of cases. We know he's a great man, and I think one of the most experienced person in the world about total knee joint replacement. But I consider he never did this popularization unless Mr. Bajpayee was operated. At that moment, any orthopedic surgeon, even common men asked, what was the surgery on Mr. Bajpayee? And we try to explain them, this is total knee replacement and this is how it is done. Now, when we are thinking of the high table to be made somehow popular, we have to explain to the patient the pros and cons, do's and do nots, so that the patient can have another 20 years flawless life. That is why sometimes from the news we find the famous singer Sonu Nigam, he underwent the knee preserving surgery called high tibal osteotomy to avoid a knee replacement. This was the 2018. So this news, if any common man will, then he will ask you that what is high tibal osteotomy? That is why I try to put it that it should not be taken as a surgery, but we can consider that is a thing which may help you, can be taken as a non-surgical method by which, but you have to look into what your doctor says, do's and do nots. The type of exercises, as Dr. Barua suggested, keep your knee straight. Never try to make it fixed flexion deformity. The first point. And second thing, whatever drugs or medications necessary, we'll be discussing about it. I completed my talk within that. Thank you.
Thank you. Thank you, Dr. Mohanty. So it's very excellent talk on this. So it can be done. So we have gathered about the early treatment, early management of osteoarthrosis, as it was previously discussed, Dr. Barua. That is only the flexion deformity is the very early changes, and if we can prevent it, we can block the progression of the osteoarthrosis, which is the demand of the day. And if it is much more progress, little bit progress, then your method will come to prevent the progression further. But we have a very important armamentarium in hand, that is medication. So every that, because these surgery, whatever the surgery, whether it's a conservative surgery or the ablative surgery like total knee replacements, it is not a cup of tea for all orthopedic surgeons, but also for the common people. Because 70% of the population of the India is not a very urban based; it is a rural based, and we are very much based on the medications. And we are very much fortunate that we have a very important armamentarium, and especially the disease modifying osteopaths, not only in a single but maybe in combination. And we'll hear from a very renowned person, that is Dr. Amulya Singh, regarding this armamentarium, whether this medication, whether we can, by this medication we can prevent the initial inflammation, which is the root of the flexion deformity, as Dr. Barua has highlighted. There's a flexion deformity that is the root of the problem, which initiated the music for progression of the disease. And we have to know from Dr. Amulya Singh whether this medication is sufficient enough, is highly effective enough to prevent this inflammation in sufficient way, so that as a inflammation is reduced. As of inflammation leads to collection of the fluid, that leads to the flexion deformity, and that means the flexion deformity may be corrected, and we can block, we have reduced the progression of the osteoarthrosis. So without wasting up time, we have just coming Dr. Amulya Singh for highlighting this armamentarium, especially the medications, how the medication will help us. Please suggest, sir.
Thank you, sir. So at this moment, I will be like a bridge between Dr. Barua and Dr. Mohanty, and try to talk in this joint pain, what we are suffering, and what already all the learned audience must have seen and viewers are seeing, that in India, this joint problem is increasing. It is such a crippling disease that it keeps the patient on bed or maybe housebound. So this is really a cause of concern for lots of us. And there is something, this UC2 combination, is it really worthwhile that we can talk on this aspect in this modern era of surgery? We all are orthopedic surgeons. Nobody wants to call himself as orthopedic physician. But what my learned friend, Dr. A.K. Pal, has said, most of us are working in periphery also, where we are not very much accustomed to all the latest development of surgery. And what is happening in India? Osteoarthritis is the second most common joint problem. This is the most frequent joint disease with a prevalence of 22 to 39% in India. This is more common in women than men, and nearly 45% of the people over the age of 65 years have symptoms, while 70% of those over 65 years show radiological evidence of osteoarthritis. This last line is a cause of concern because we know that Indian population is aging. The same population which was not working, now they are working till around 75 years, 80 years. And if the patients have lots of pain around the joint, it is very difficult for them to be mobile. And also in this era of single family, I will say, where the attendants are not there to take care of you, you want a pain-free life. So problem, this is my hospital. That day the lift was not working. And what is happening to this lady? 48 years old, crippled, not able to walk on stairs. She needs all this support. So what happens to the cartilage? Already you all have learned there is problem in the articular cartilage. As it gets degenerated, the bones are getting exposed, the free nerve endings are getting exposed, and there is lots of pain. So just to counter all those pains, our goal of management as a physician, I will say, we want to reduce the pain of our patient. We want to improve the function of those patients. Yes, the lady or the male members want to do their activities of daily living independently. They don't want any support as such. And also, the supports are very costly these days. It's not easy to get a good household help in the modern era at a lower cost. You want to improve quality of life. You want to slow down the progression of disease. If you are having a severe pain around 50 years, 55 years, you may be living for another 25 years, 30 years. How the progress of disease can be slowed down? And especially, we want to prevent the NSAID-induced adverse effect, especially GI complication, the kidney complication, and the cardiac complications. The most important is we want to improve the quality of life. Here comes the role of early intervention. Yes, stage 1, stage 2, we will be talking. What you have learned from Dr. Mohanty, stage 3, stage 4. Problem is that you can't change all those degenerated, all these deformed joints. So our initial key will be early intervention. If you are not managing initially properly, then it will go to stage 3 and stage 4, where the only option is surgery. So early intervention has been shown to be the key to optimal osteoarthritic management, but unfortunately has often been neglected. We as a clinician, not blaming only the patient, we as a clinicians, we don't convince, we don't counsel our patients properly. And that's why these patients soon progresses to from stage 1 to 2 and 3 and 4 gradually. So primary care providers are first line of evaluating and treating osteoarthritis. We have to encourage patients for the exercise. What you have learned from Dr. Barua, proper, very well explained, everything you can manage at home. You don't need a very good physiotherapist as such. You all can manage at home. So we as a clinician, we should learn. Then only we can tell our patient that, okay, you do all these, then your disease progress will be slightly towards a better side. You have to lose weight. Yes, obesity is a big culprit these days, and utilize physical therapy. We have all learned about this. Surgery should not be the first option. This is mandatory. The lady, when she's not able to walk all alone, she needs all those support. But surgery should be the last option. Even all those big organization associations telling it. So what to do in our those crippled patient of stage 1, 2, and maybe early part of stage 3? ACR guidelines First is a non-pharmacological modalities, what you have learned already from Dr. Barua. Paracetamol can be one option and even tramadol. But along with it, a big role is coming of nutraceutical. Lots of studies have come in the last 20 years. We started from glucosamine and gradually we have progressed to lots of other drugs like chondroitin, methylsulfone, methane, rosehip powder, etc., etc. And now the era of collagen. Why, how, when? Yes, we will talk because we want to prevent the complication. We don't want that our patient should go for surgery. Nutraceutical, a big thing for this era as such. In this era of surgery, I'm talking of physician, physical role, physician's role. Yes, we have got rosehip extracts, undenatured type 2 collagen, alpha-pin, vitamin D, all these drugs which has come in the market, lots of combination. Now the confusion is starting in our mind, which one to use, because we had used lots of glucosamine. Many people called it as a placebo drug. Nothing is there. But those people should realize we got relief in stage 1 for some years. But now we moved to some more because we were not satisfied with glucosamine. We were not satisfied with chondroitin. So there comes a new molecule, collagen peptide. What is it? Collagen is a nutritional supplement made from animal or fish material. Generally, it's coming from chicken sternum. It is rich in amino acid that plays an important role in the building of joint cartilage, and it may have anti-inflammatory effects. Friends, we should realize that osteoarthritis is not our old concept of only degeneration and degeneration. There are inflammatory mediators which are getting acted through cytokines and interleukin. So we now need some anti-inflammatory agents also to control the progress of the disease. But eating collagen only, if you just eat collagen, our body doesn't treat amino acid derived from collagen any differently than any other protein source. So if you are just taking raw collagen, you may not have benefit on your joints. For this reason, the ideal that normal collagen supplementation can be an effective treatment for joint pain, osteoarthritis, or any other condition is highly implausible, if not impossible in principle. This is very important, that only collagen peptides may not help you. Then what is the option? That is the reason our concern changed to undenatured collagen type 2. Another supplement, yes, a part of collagen. And what is the difference? The first, what I am going to talk to you is undenatured collagen, is non-hydrolysated type 2 collagen. This is the biologically active form. We want a biologically active form. But denatured collagen is hydrolysated type 2 collagen, collagen that has been broken down into smaller peptide molecule. And therefore, because this acts only as an amino acid, our chondrocytes are not responding to it. So what our body wants, our joint want, is undenatured collagen type 2, not type 1. Type 1 is for soft tissue like facial muscles, etc. Dermatologists are using it. But type 2 is specially there for chondrocytes and joints. This is the second most commonly used nutrient to alleviate pain associated with arthritis. The most common which we were using is glucosamine, but undenatured type 2 collagen may be twice as effective as glucosamine and chondroitin for joint health with a better dose compliance, means once daily dose. Glucosamine you were taking thrice daily, about 1500 milligram per day, 500 milligram capsule thrice daily. Here 40 milligram is giving you a very good safety profile, very good dose compliance, and you are getting a good relief also. So clinical evidence I will be talking because you have already heard about this knee braces, etc. You have already heard about the merits and demerits properly by Dr. Mohanty. So he has expressed it so well. So I will be just giving in brief. I don't want to go in all those pharmacodynamics, pharmacokinetics, so that you will be really feeling bored. But the comparative efficacy, what you see, the blue line and the red line, the blue is comparative reduction in the WOMAC score and VAS score after 3 months in undenatured type 2 collagen versus combination of glucosamine plus chondroitin. This undenatured type 2 collagen is giving a better reduction in WOMAC score and reduction in VAS score. Patients for better quality of life want less pain in the joint, and this type 2 collagen undenatured is giving that benefit. Knee extension was better. What Dr. Barwa told, you don't want a flexed knee. Here, this once daily dose is giving you a very good movement. What you can see in this diagram, knee extension was better when compared with placebo. So once daily doses is giving you much better results within 3 months. Efficacy and tolerability of an undenatured type 2 collagen supplement in modulating knee osteoarthritic symptoms. A multicentric randomized trial was done and it is very well tolerated. Best is this, almost no side effect. This improved the knee joint symptoms. The pain stiffness is less and very well tolerated by our patients. After leaving that undenatured type 2 collagen, next in the list is Mobili, oral hyaluronic acid. This is a patented ingredient and this multiplies the natural production of hyaluronic acid inside the joint. We all know that hyaluronic acid is there in synovial fluid, which helps in nourishment of cartilage. And this mobily multiplies the natural production of hyaluronic acid 10 times. So that's why it's beneficial for the joint. This stimulates the endogenous hyaluronic acid production, reduces joint discomfort and inflammation. Here it is acting on this inflammatory cascades, and you are getting lots of all those inflammatory mediators inside the joint. So a better response is there. Third in the list is aflapin. Aflapin is patented, selective, and the most potent 5 lipoxygenase inhibitor. Means this is acting on another pathway. There are 2 pathways on which we want a good drug to act: cyclooxygenase COX pathway and LOX pathway. This is acting on the LOX pathway, and this significantly reduces joint pain, inflammation, stiffness, and a physical function compared to placebo is much better with aflapin, means Boswellia serrata extract. This significantly reduces matrix metalloproteinases levels, chondrocyte proliferation, and increases the glycosaminoglycan GAG level, therefore providing cartilage protection in arthritis. When we see about the clinical evidence, this is capable. Aflapin is capable of inhibiting cartilage degrading enzyme MM3 and has the potential to regulate the inflammatory component by inhibiting all those enzymes. This is a fast onset of therapeutic action in osteoarthritic patient, and this significantly improves the joint function, relieves pain as early as 5 days of treatment. Because of its anti-inflammatory effect, we are getting a much better early, so you don't need any analgesic and NSAID. One drug in combination is giving you relief, and the fourth drug on which I will be talking is curcumin. Curcumin is a compound derived from the dietary spice turmeric. We all know from our village day, rural days, we all know haldi, turmeric, how much it's useful for pain. People do it with milk. They mix some haldi or turmeric and drink it. You apply turmeric on the swollen joints or the acute painful joints. So curcumin has been used for centuries in traditional Chinese and Ayurvedic medicine for its anti-inflammatory properties. The only thing is that now it is coming in pure form as curcumin. There is some evidence that shows curcuma has anti-inflammatory, anti-thrombotic, antioxidant, and antimicrobial activities. And because of the anti-inflammatory activity, we want to use it as one of the drug for our management of osteoarthritis. Now the thing is that how four together is going to help. Why we are taking the synergistic action of UC type 2, mobile, boswellia, and curcumin, undenatured collagen type 2. This modifies disease pathophysiology of osteoarthritis and prevent further damage to joint structure. Mobile, significant improvement in knee pain, discomfort. This increases the muscle strength. What we were talking about, the quadriceps strengthening exercise, and this reduces the inflammation also. Boswellia, this improves the joint functions and pain relief. Curcumin, this has got an analgesic effect, similar efficacy, but better safety profile over diclofenac has also been there in the studies and literature. So one by one, when you move from UC type 2, mobile, boswellia, and curcumin, each are supplementing the action of others. So it is a synergistic action. All together, we are talking, why not take food together in one tablet? And when you are getting it, the result will be awesome for the patient. Finally, coming to the summary, combination of above mentioned 4 nutritional supplement may be safe and effective in patients with early and mild to moderate osteoarthritis. Never talking on third or fourth grade. Combination of these drugs can also be effective in patients who are not able to tolerate NSAIDs. It can also be preferred in elderly population. This is very important, on which I was talking. Elderly population to avoid complications of long-term uses of NSAIDs. So it is a safe drug, can be used in our patients. So why not take it once daily tablet to reduce all the discomfort of pain, stiffness, and you will have a better quality of life. For the treatment, the doctor is the final judge. This is the left side is the normally, right side is osteoarthritis. We want a perfect match to manage it so that we can have a safe journey on road. So find your perfect match. This will help us. And for this better quality of life, we need a good synergistic effect of orthopedic surgeon, physician, physiotherapist, occupational therapist, orthotist, and counselor. All together are going to give a good result to our patient so that a teamwork will help this type of patient also dance and sing in a much beautiful way. Finally, over, and thank you very much for giving me all the precious time. Thank you very much.
Thank you, Dr. Mullo, for your excellent deliberation of and highlighting these medications, which is, I think, it is excellent and highly effective for the early osteoarthrosis, for reduction of the inflammation, basically. Because we cannot in osteoarthrosis, basically, what is the term? There is a two term. One is osteoarthrosis and osteoarthritis. So who has come the first one? The debate is going on and on. Osteoarthrosis is basically the primary one because it is the degenerative one, and after that it ultimately leads to the degeneration of the articular cartilage and ultimately lead to inflammation. So once the inflammation has sets in, there is osteoarthritis. So there is a main role of medication is to reduce the inflammation. There are several anti-inflammatory medications are in our hand, but we cannot extend these as cannot extend that use of this especially the analgesic anti-inflammatory, that is NSAIDs, for more than 10 to 14 days or more than 3 weeks. That is why there are several drugs as nutraceuticals has come, and it's basically the disease modifying anti-osteoarthritic drugs, which are basically, as you have highlighted, there's a combination, especially the undenated collagen peptide type 2, and also there are some other nutraceuticals for this rescue medicine, which is highly effective to reduce the inflammation in the long term. And basically, if they along with the other treatment of choice like I think the physiotherapeutic measures, lifestyle modification, and increasing the muscle power around the knee, that is unloading of the muscles by biologically, as also with the help of the osteo. There are some equipments. You can easily save the joints if we get the patient in very earlier form. Thank you, Dr. Amollo, for his excellent talk on this. We'll discuss, and if there is a question, will come again for all panelists. And before that, we have just start with some real life cases. So I'm trying to share my screen. Okay. First, I shall just highlight the questions, the problems, and then we'll come to the panelists. And by order, I will come first to the Dr. Barua, then Dr. Mahanti and Dr. Amula Singh. And if there is any questions in the meantime from the audience, I can highlight that question also. So first of the case is 46 years old female, says BMI is 34.2, is complaining of pain in both knees since the last 4 months, but suddenly increased pain while getting up, especially from sitting for a long time, since 5 days in the left knee. And see, this is the clinical scenario. That is the female sudden onset painful swelling just for last 5 days, especially on the left knee. And this is the normal this is the usual sitting posture of this lady, and then specialist complaining of pain after flexing, but more than that. And see, there is some fullness of the around the knee joint and little bit puffiness of the whole left lower limb. So this is the scenario. And I think there is a basically this is the problem. So basically, what is the problem, Dr. Badua? How to approach this case, Dr. Badua?
We need to, can you hear me?
Yes, please.
Yeah. So basically, this is an osteoarthritis. Is been diagnosed to have an osteoarthritis in this case, right? Or we need to work out. I think let us stick that this is an osteoarthritis, right?
You are right. You are right, because this is the bread and butter of our clinical examination.
Yeah,
Dr. Mahanti,
yeah.
can you add anything on this?
Now, that is what Dr. Barua was saying. A 46-year female.
Yeah.
Giving-
So that is common. That is a common diagnosis of osteoarthritis. But see the age. It is only 46 years age. So that is the problem. So usually we have learned from our teachers that osteoarthritis is a disease of the older age. But now the patient is the several relatively younger patients has come with this complaint. Now in that case we have to rule out the other causes. So the osteoarthritis, yes, it is osteoarthritis. But the whether the pain of the osteoarthritis is coming, it is due to the synovitis or the arthritis, or there is some periarticular bursitis. Why I am thinking so? Because the age is very less. It is only 47 years. Okay, and as the as you see the BMI, it is little bit more. It is 34.2. There is a little bit obese patient. So in that case, so in all of you know, in the obese patients, as the joint is extremely loaded and there is some excessive there is fluid inside around the different types of bursa, so there is a possibility of bursitis. Dr. Amullo, so in your opinion, what are the different causes? It may be due to some synovitis or arthritis or some periarticular bursitis. So what do you think of, Dr. Amullo?
I think
Hello?
he has kept his thing mute. I think Dr. Pal.
Yes, please.
Hello.
Yes.
Can I just say something in this
Yes,
point?
please.
Yeah. I think although the patient is less of age, 48, I think we have found cases in 30, 35, 36 years,
Yes,
especially in
yes.
females, number one. Number two, since patient does not have any generalized signs and symptoms, and it
Yes.
is a monoarticular fusion sort of things, osteoarthritis, the pain is basically a synovitis with a reaction to the cartilage debris which is floating inside the joint. Now, in this type of cases, one point should be kept in mind, because the patient had started complaining of pain after getting up from a sitting posture for a long period of time. So what I feel that we should rule out in this case, internal derailment of the joint, like meniscal tear or something like that.
Yeah.
So we need to
Absolutely
go
right,
into
sir.
the
Absolutely right. But I think don't think that she is very active person. I think he's a old obese lady. He's a actually housewife. So I think you are right. So if it is a younger male patients, even relatively much more younger, then we have to keep it in mind. There's an internal derangement of the knee, as you are rightly mentioned. It is highly. It is why we have to point it out by all person. That is any internal derangement of the knee, especially the medial meniscus tears, or any ligament tears, especially in the soccer players or in the in any.
No. I'm talking about in an osteoarthritis scenario. If sudden pain.
That is I'm telling.
Yeah.
I will come in a talk, because it is seen that those who are having the internal germinal knee in the earlier phase of life, ultimately they causes the degenerative arthritis relatively earlier. That is the main problem. So that is the relevancy. Okay, we'll come. So there are several presentation of osteoarthrosis, some like intermittent episode or maybe constant episode. Intermittent episode, maybe there is a occasional pain following inactivity, which is the classical symptoms, or there is unable to walk with high speed. This is sometimes the patient may talk like that with normal speed, with prolonged period, it is unable to do, or is unable to stand for prolonged period, or pain during the use of staircase. Why I am highlighting this? Because these are the very early symptoms. We have unless we pick up the early cases, so it is very difficult to prevent the progress of the disease. And there may be constant feature, maybe chronic dull ache, or there is acute exacerbation of the chronic pain with intermittent swelling because of the collection of the fluid, or there is severe painful restriction of the joint motions. That is also another possibility. So how to diagnose the synovitis and arthritis? This is the concern. So arthritis is basically likely when the pain is aggravated by the movement and is associated with the loss of motion. This is the most important. Pain plus loss of motion.
Yes, you're very correct. Hello. Hello. Hello.
But the tenderness is elicited by palpation. And hello, am I visible?
Yeah.
So, and the synovitis is basically when there is a pain is there, but the range of motion is almost full, or maybe it is terminally painful or restricted. So in that case, even in spite of the joint line may be tender, so this is basically synovitis. So why I'm highlighting this? Because so we have to diagnose properly. So if it is at all a joint problem, if it is a synovitis stage, so that can be completely reversed. Otherwise, it is arthritis that will gradually progress. Now, as Dr. Barua has highlighted, so this reduction, this is a radiograph of this that person. There is a lady. You can see here there is a mild reduction of the joint space. Now, now the question has come as per after the lecture of Dr. Barua. So, is it optical illusion? So, is it the actual reduction of the joint space? Is it that due to reduction of the cartilage height on the medial space? Maybe, may not be, because if there is a effusion or any inflammation of the joint, that leads to flexion of the knee, as this principle as highlighted by Dr. Barua. So if there is a flexion of the knee, so posterior part of the condyles is coming in articulation, and that may
Hello,
that is
Dr. Pal, your share screen has been disabled. Just share the screen because we can't see the
Your X-ray. We can't see the X-ray.
okay. Just I'm sharing. Is it visible now?
Yeah.
Yeah. So, is it optical illusion as Dr. Dr. Badua has just highlighted? So, is it once there is the inflammation, there is a flexion deformity of the femur of the joint, and in that case, the posterior part of the condyles is coming in articulation. So, how it can be proved? So, there is I'm supporting Dr. Badua's view is that. So this is the classical radiographic feature, as there's a reduction of the joint space, subchondral bone. So there is a sclerosis of the subchondral bone, the cyst formation, and the osteophytes. These are the four radiological criteria. But there are some other features. So how to substantiate? I will come. So I'm come to the panelist. So is the other investigation like full length radiography is required? Is there any other advanced investigation is required for planning of the surgery, or how to investigation? Which investigation is required for early diagnosis of synovitis? Is there anything?
For the cartilage, I think at this moment we have two investigative procedures.
Yeah.
One is non-invasive, this is the MRI.
Yes.
MRI can tell us about the thickness of the cartilage.
Yes.
But in some of the studies that I have gone through, it is not very conclusive. It's not very conclusive.
Exactly.
Second is your arthroscopy. Even you can do as an outdoor procedure under local anesthesia, and then you can look into the cartilage. And surprisingly, the early osteoarthritis, we believe that it starts in the tibial articular cartilage, but surprisingly, it starts in the posterior part of the femoral condyle. the cartilage changes in that area. Whatever cartilage changes you see, that starts in that area. The moment the flexion is corrected, I think that unloads the posterior part, and then you see then early recovery of the. This is our hypothesis.
You're right. You are right.
But
You are
once you see the osteophyte, marginal everation or the osteophyte, I think already cartilage is gone, being destroyed.
exactly. So you are rightly mentioned, sir. So next is coming the value of the full length radiograph to diagnose the tibia vera or the bowing, as is if it is the key, if it is the cause of this genuveral deformity. And now this is the subject of the treatment by Dr. Mahanti. So in that case, if it is a tibia vera, you have to easily correct it by with the help of the gradual now I'm coming to that part. So as it is a SUS view, so it can be taken in this manner. So it is a 30-degree flexion, and it can be taken from back. So the exit beam will be from back, and the plate will be in front. So in that case, if we easily diagnose the actual joint space of the posterior condyles, see that is same patient showing as a so the initial radiography. If you mentioned that, so there are if you remember, so the medial joint space is reduced, but here it is joint space is maintained. That means the theory of Dr. Barua is absolutely right. That means it's an initial period where the joint space narrowing is showing that it is not due to the actual reduction of the
I can't hear you. Can't hear you. Can't hear you.
preserved joint can be made that it is done in this case like this. See, if it is active, ortho-non-genogram is there, seeing that is planning can be made in this manner. So how much correction is required during this surgery? So every joint preserving surgery requires this sort of planning, otherwise it may fail. So in stage 1 or stage 2 osteoarthrosis, this sort of investigation should be done. So, and another important point is the alignment. This is orthoronjogram. Standing orthoronjogram is important because in a neutral alignment, there is 55 to 70-degree load should be transmitted by the medial compartment. But if it is a simple 1 degree varus from the neutral alignment, there is an increased medial load by 5%. On the contrary, if there is a valgus angle of 3 degree, there's a more load has been unloaded on the lateral compartment. There is a high survival rate. So this is most important. Now the point is how to diagnose the early synovitis in the investigations. Now I'm coming that's MRI, because a synovitis is the first stage. If we have got that patient in the first stage, in the synovitis stage, we can reduce the speed of degeneration. Now the question is, there is some 2 points. One is synovial proliferation and the effusion. So there is a race is going on always. There may be, if we neglect the patient, there may be increased synovial proliferation, or if it is a significant reduction of the articular height, that may lead to friction and the arthritis effusion. Now this is the special investigation of choice. It is now coming in a big way. That is dynamic enhanced MRI, that is DMRI technique, which can quantify the amount of synovitis in the weight bearing areas of the condyles. This is most important. As you can see here, there's a synovitis maybe quantified maybe 20%, 30%, 40% like that. If it is more than 40 or 50% joint is involved, that is a very bad prognostic indicator. Another important point is joint effusion. And this joint effusion, that it's a significant effusion can be easily diagnosed clinically. But if it is a mild effusion, that investigation of choice is the MRI, where there is best detected on the fat suppressed T2 weighted sequences, because side joint is very important for visco supplementation. If we plan for visco supplementation, joint should be almost not almost dry for their effectiveness. Now I'm coming to the panel. So what is their opinion? That is there any correlation is there between the symptoms with the lesion size, or whether is there any predicting indicator of this MRI findings with this progression of the osteoarthritis? Anybody, Amollo, please, can you give any light on this?
What is your question?
Question is, these are the usual findings in early osteoarthrosis. Now, is there
Mhm.
any correlation between these symptoms with the lesion size? Lesion size means that is synovial proliferation or diffusion, or any findings on this the MRI findings, along with this any correlation with the investigation finding along with the symptoms. And another, if there is any predicting indicator, how is whether I can predict it, whether these changes can progress very rapidly or not.
Now, if we look into the basics in osteoarthritis, it has been said for a very long period of time that even in presence of advanced radiological changes, symptoms may be very minimal or may be absent in some cases.
Yes.
But with very minimal changes in the X-ray, even symptoms are more. So
Yes.
this myth is yet to be solved. This is number one. Number two, the MRI tells us about the pathological changes that has been taking place. But the patient in general may respond in a different way. And then if we just depend on the MRI, probably we'll be at lost. So
Exactly.
it has to be correlated. It has to be correlated. And number two, the amount of synovitis, it all depends on the amount of inflammation that is going on inside the joint. More inflammation, definitely, there will be more painful symptoms. You cannot deny the patient, the joint cannot deny the physician to make a diagnosis of synovitis, because after all, synovitis cannot be taken in a lighter form. So I think synovitis appears in a knee joint in osteoarthritis in a little later part.
Exactly.
In the beginning, it is a very mild form of inflammation because of that we have discussed already, milder form of inflammation. Cartilage is aneural, it is no lymphatics, and so it does not give any pain. The pain is because of subchondral microfractures, because the cartilage is inuded. Definitely, there will be stress on the underlying bone, and those underlying microfractures may heal. It may lead to increased venous congestion. So, in this scenario, it is the weight relieving or unloading of the joint which is very essential. And at the same time, yes, I think we should think it that way.
Absolutely right, sir. So you have highlighted you have made my job easier. So that is why you have highlighted the subchondral fracture. That is
Yeah.
basically leads to the subchondral bone lesion. And this is these are the they are now this is the becoming, there are several papers are coming. So if there is a subchondral bone lesion, that may be the important prognostic indicator. The initially that leads to fracture. There is a collection of there is a fluid. The radiographically it will looks like a cyst, subchondral cyst,
Yeah.
and
Yeah.
subchondral cyst, and that basically histopathologically that is initially there is necrosis, and once it is healed, it is healed by fibrosis, and there is a that may be to acute exacerbation that lead to edema. So this is if these features are seen in this in this MRI. So these are that amount of the subchondral bone lesion is the actually predictor of radiological progression. So another is the reduced bone marrow lesion size associated with reduction of the cartilage degradation. So we have to see how much cartilage degradation is also there apart from this. This is the cause, and the effect is the cartilage loss. So we have to see how much cartilage loss is there by cartilage. There are several other studies also. Yes, and you are very right in this manner. It is evidence. It is proved by the different workers. This pain is directly correlated with the lesion size, and basically it is directly proportional to the inflammation, as you have highlighted. And it is a highlight. The Lotke et al. 2000 has published this. And the lesion size is more than 1 centimeter is correlated with the cartilage loss directly, as per Sowers et al. 2003. Now the problem is how will detect the cartilage damage. Now this is the radionuclide scanning 99, and that can easily map the cartilage loss. But another important easier investigation has come. Just I am highlighting this. So this is the investigation. This is a delayed gadolinium enhanced MRI of the cartilage, digimeric early study of the early osteoarthrosis. Basically what happens, the cartilage, they have a negatively charged glucosamine glycans. So there is GAG is basically negatively charged. So if the cartridge is healthy, so it has a plenty of negatively charged GAG particles, which actually repulse this GDTPA, which is also negatively charged. But if the cartilage is lost somewhere, so there is a lack of these GAG molecules, negatively charged GAG molecules, and in those areas there is a high intake of negatively charged GDTPA, and that is actually captured by the radiograph. So this is the area. See, in that case, there is only this is the area, and this is the area where the cartilage loss is there, and that is a map by this digimeric study of this in this case, in that lady. So this is the case. Now the panel is, now who are prone to progress of this. So what are if there is any the lifestyle which is very much prone to that progression of the osteoarthrosis, or any predisposing factors, or any genetic predisposition. So what is your opinion from panelists? Anybody? Dr. Badua, please.
Yeah, who are prone to progress?
Yeah.
If we look into the literature available, some of the genes have been identified
Yes.
to be the root cause that some cases, some persons develop osteoarthritis with minimal amount of occupational hazards, but some others, they do not. This is number one. Number two, in one of the studies, it has been said, it's not only, it was basically a review study. It has been said that uh, it is not the obesity alone, body weight. This is also important.
Yes.
You see, there are two things. One is obese, and another is body weight.
Exactly.
Some people, even without too much of body weight, they develop quite significant osteoarthritis. Lean body, even then they develop osteoarthritis. So there will be some genetic factors in those. And secondly, occupation, yes, why not? Then another important point, that how many of the housewives, I mean the people, the maids, they develop osteoarthritis. They have to squat in the floor, mop the floor. They keep on coming days after days and months after days to our house and then mop it. How many of them develop this osteoarthritis? Very minimal, very minimal. But it has been seen that people who are exposed to some amount of abuse inside the joint in the form of taking up exercises recently, very vigorously, probably, and they have, because the degeneration starts immediately after birth. By the age of 10 years, the degeneration is almost complete, especially in the your intervertebral disc. So it all depends on the how the person is being, because at by 30, 35 years, they keep on earning, and suddenly they see that the tummy is big, they are putting on a lot of weight, then suddenly they start doing those exercise and walking and cycling and whatnot, and then they are prone to develop this. Any predisposing factors that I have said, yes, one is your genetic factor, one is your environmental factor, especially the professions, in what professions they are having. But surprisingly, we do not see a lot of osteoarthritis in village people who used to work almost 10 hours a day in the paddy field. They squat for a long period of time in the paddy field. They carry weights and other things. It is osteoarthritis is probably a disease of the sedentary workers.
Exactly.
And it is genetic predisposition. It has been proved in primary osteoarthritis, genetic predisposition. Yes, it has been proved by that gene is a defective gene is responsible for this. I think I have got this about idea about this.
Exactly. You are right. So, anybody, anything, Dr. Mahanti? What is your opinion, Mahanti and Dr. Amulla?
Comes around the genetic predisposers.
Right.
Everything comes around that. But I'll suggest you one thing, that the people who are having osteoarthritis, maybe at 40 or 50, some of them are osteoporotic. And once a person is osteoporotic, the fracture, what you suggested on the middle side of the upper tibia, is they are very prone to it. And when we see in the X-ray there are osteophytes, that means already there have been a depression with the extra bone, because the nature comes with new bone formation when there is a weakness in the bone. So what I feel, as we have been seeing cases like cervical spondylosis, we do the X-rays only to exclude other conditions like tuberculosis or malignancy, because as Dr. Barua said, Dr. Singh said, that sometimes you find gross changes in the spine when the patient does not have any symptoms, whereas sometimes you get no finding in the X-ray and patient has a lot of symptoms of neurology. So same thing holds true for osteoarthritis. And finally we come that some people are very prone to it, maybe genetic predisposition, nothing else.
So, you have highlighted another important horizon, that is, if there is osteoporosis is already there is a high chance of progression. You are absolutely right. So, any other points to be noted from Dr. Mamulla?
I
Amulya,
think
please.
Amulya has already left. He has got some VIP patient.
Okay. So you suffer. You have already enough discussed about it. There are genetic predisposition and some specific occupation. Those who are using their knee with very bad, and housewives have highlighted. And some housewives are very much fond of wiping of the floor in our villages. So they may be related with the osteoarthritis, maybe in this manner. So high body weight and this genetic predisposition, especially the MCF2L gene, is most important for responsible for this, as Dr. Barua has highlighted. So this is also another important point. And Aaron De Williams, 2011, who have highlighted this gene, which may be responsible for this development of osteoarthritis. Now the question has come: can the progression be prevented? So any panelist can brought the light on this.
See, it is what we were discussing from the beginning is, can it be prevented? So
Yes.
the thing is, we are all the time trying to educate people that try to reduce your body weight, try to do this, don't do this, and the moment you have it, so obviously what a clinician normally tells a patient how to prevent it is to avoid osteoporosis along with that, and to reduce weight. And if sometimes the person comes and tells him, my mother was having all these symptoms and now I am having it at an early age. Maybe there we explain about the genetic side, and the moment you look at a person who is gaining weight, we tell them to reduce it. And these are the things what we have discussed from the beginning to the end. And today, if you ask me to be pinpointing what will be the thing to prevent a progression, I think today's lesson from the evening will be that we prevent a fixed flexion deformity in these patients, so that from the beginning the quadriceps can be strengthened and the patient should not lose the locking mechanism of the knee. By that, possibly, we can reduce the chances of progression. Otherwise, nothing else is there.
So can I just tell
Please.
something into this? Yes.
Yes, please.
So I think thank you very much that you appreciate my hypothesis that flexion is the culprit of all the osteoarthritis. Acha. A second point I want to tell you, it's not a generalized like you reduce body weight, you do this exercise, you do that. It is all it should be very case specific, and it will the stage at what you are getting the patient. So it will be case to case at what stage you are getting the patient, because at 30 years of or 35 or say 30, 40 years of patient may not have a very big reduction of proprioceptive sensations. Secondly, muscle strength may not be too much loss in those patients. So in elderly patients, past 50, 55, 60, 65, those years, I think sarcopenia and the proprioception, they play a very big role in preventing the progression of the disease. But the younger patients, we should look into their the daily activities, what they are doing, So change of, it's not possible in Indian scenario to change the profession. You cannot just tell them that you stop driving your, he is a driver, you cannot tell him that you stop driving your vehicle from tomorrow. So change of profession is also not possible in our scenario. I think individual cases, look into the patient at what stage the patient is at, and then go ahead with your suggestions and treatment. And most importantly, the patient should have confidence on you, because if you tell him that you reduce your body weight, it's not going to help him. So how do you reduce the body weight? So there are so many others. So we should be prepared. I think the orthopedic surgeon is basically should be a clinician before he becomes a surgeon. It's very important that that is happening inside the body, and accordingly we choose the patients and suggest them and keep them under our surveillance for a pretty long period of time. I think this is one very important point that I have been
Absolutely right.
following in my, yeah, yeah.
So it requires multimodal approach in a nutshell. So there are
Yes.
there are several ways. I'm not going into detail. So now, can surgery can prevent osteoarthritis? There are several discussion we already done. So it is not. I think it is over. This emphasized. Now the presentation pattern is already there. So the basic aim. So basic aim is a symptomatic relief of pain which is arising from the nociceptors initiated by the inflammatory mediators, mechanical strain on the nociceptor, quadriceps weakness, and the effusion as highlighted. But still some patients remain unresponsive. And basically there are chronic pain. Just I want to highlight this one. This is a neuropathic component. Neuropathic component may be added along this chronic pain, and which should be kept in our mind. Otherwise, it will be very difficult to give symptomatic relief. Now there are
And
several.
there's another one point, Anand. There's another important point we should not miss it. You see,
Yes, please.
we always talk about the joint above and the joint below in the examination. So it
Yeah,
is very important point you need to find out. In some of the ankle and subtalar joint problems, those patients are very prone to develop osteoarthritis of the knee joint. If you ask them to reduce weight, you take this diet, you do this exercise, but if you do not take care of those ankle and subtalar articulation problems, probably it's not going to help us. So it is very important. Even in physiotherapy, they try to improve these ankle and the subtalar joint. They try to evaluate and try to find out whether there is a malalignment or something like that. So I
exactly.
think this also comes into play.
Yeah, you are right, sir. So now we have these medicines we have in hand. So among the analgesics, so which analgesic will you prefer, sir? Any guidelines? Which analgesic? Because this is the mainstay. Without symptomatically, we cannot gain the confidence of the patient, isn't it? So you start with the analgesic, then the DMOD or the nutraceuticals will come, isn't it? So which analgesic will you think of in the first?
I personally, at the beginning, when the pain is very severe, I start with itracoxib. Look into the patient's blood pressure and other things. If it's suitable, I start with itracoxib maybe for 10 to 15 days. Then I switch over to acetaminophen. Acetaminophen in a sustained release, 1000 milligram per day is a very good drug. This can be continued not less than for 1 month and 6 weeks, even up to, you can go up to 6 weeks, not an issue. At one point of time, the coxips were there, but somehow they have waning out. I don't find anything very suggestive of coxib. So itracoxib for the severe acute cases. Otherwise, I go for acetaminophen.
Okay, okay. So Dr. Mahanti, do you have any other predilection? Dr. Mahanti. Okay, so regarding analgesic, there is another important analgesic which is very age old. Now it is coming in a big way. There is a piroxicam, because it is some studies have shown that the piroxicam has a very increased concentration in the synovial fluid. So there are some bad side effects are there in the piroxicam. That is why it was not very much popular. But there are some. There is also that is coming in a big way. Now the DMOID, I've already it is highlighted, that is the undesatured collagen peptide type 1, this curcumin, that is the methyl glycosamine methane, and this combination is extremely effective for reduction of the inflammation in a long way. Once we want to give some these drugs, because these are slow acting drugs, because it requires some time, that is 3 to 4 weeks time it is required, and during this period some analgesics is required for relief of the symptomatic relief. So now it is you have right, Amulya, you have just rightly you have entered in right time. So what is your opinion? So regarding the what is your line of management of the drugs? Because we'll always start with the analgesic and along with the DMOD or the nutraceuticals. What will be the combination?
Frankly speaking, sir, I'm really sorry I missed some part of your beautiful deliberation and also a discussion.
Carry on, please.
So this analgesics, generally we have to, if the pain is severe, we have to believe in it, because initially I can't believe on my DMORD. So any type of analgesic, as dependent on the age and the different parameters of the patient, I will have to give for about 5 days. Then for stage 1 and stage 2, I have full faith in my disease modifying osteoarthritic drugs. So either I go for, initially I was using glucosamine and chondroitin sulfate, but these days I have very good result with my denatured collagen type 2. So I am going for it. And steroid, hardly, sir, very few I have gone for steroid oral form, but sometimes in very acute case, one dose of injection I can think of, sir.
Thank you. Thank you. Yeah, please.
Anand, one point here. What about diacerin?
Yeah, that is
Role-
under the cover of all the DMOID. Yes, Dicerin is also a very good product also. So you can use that Dicerin also.
No,
But
actually, when the glucosamine, then all those things came in the market, diacerin came little late. The mechanism of action of glucosamine and the those other chondroprotectives, so-called chondroprotectives, mechanism of action was not very clear at the beginning. Now they are talking about the as Amulya has already told us. It is they have got an anti-inflammatory action also. But these two products one should be very careful using in diabetic patients, because they have gotten uh, that insulin inhibitor action into them. And diacerin, I prefer diacerin. I use it for a longer period of time, 3 months to begin with. Then I go up to 6 months. They inhibit the nitrous oxide, NO, which is being secreted by the dearranged chondrocytes in the cartilage. So they neutralize this. So mechanism of action was very clear from the beginning. So I was attracted to this molecule, and I'm getting good results. But I'm not very in the favor of giving glucosamine and the other combined therapy.
right.
But collagen, yes, collagen is coming up in a bigger way. But then if you just give collagen, it's not going to help, because it uh, need to be some like your growth factors and other things has to be there, so that they can be carried easily to the molecule. That is why a collagen, I think it has to be combined with some other, like your fatty acids and other things, lipoic acids and other things would be there in combination. Then only they work. This is my concept, and I work in that way. I don't know. Omulya may be different in this point.
No, you may
Sir,
be right, sir.
diacerin I have personally used a lot, sir. It is very good whenever there is some inflammatory action inside the
Yes.
joint. When the
Yes.
ESR, CRP especially are raised, it's really good. But in pure degenerative, it is not giving us a very good result. That's why many times it is a combination of glucosamine and diacerin also came in the market. And diacerin, sometimes I have felt there are some gastric problems also. So these days slightly less in use from my clinical practice, but I was satisfied whenever there was some inflammatory matters. Diacerin was giving us a very good result, sir.
Exactly right you are. So so we can have these. There are several medications where we have variations are there. We can use this particularly this patient is usually treated with this initially the paracetamol, followed by the etoricoxib, as the age is relatively younger and the patient is not hypertensive at all. So initial period of paracetamol 650 milligram thrice daily for 10 days, along with some etoricoxib, that is a 90 milligram at least 3 weeks. So it is given. Along with that, there is orcerinc2. It is used in this case for at least 3 months, and let us see the results. So basically, this is the pyroxene. I just highlighted this because This is one study has come. I have not used this drug in this case, but it is coming in a big way, because some study shows that the concentration of piroxicam is very much high in synovial fluid. Now, these are the some questionable roles of the different techniques. Have you any information on this, sir? Electrostimulation techniques, radio frequency ablation, and acupuncture. Maybe they're used in some.
I don't have any.
I don't have also, because as there is some these are the treatment options in some corners of the India. That is I'm kept it. Amuluk, do you have
Sir,
any?
no idea about the radio frequency ablation as such, but electrostimulation technique, acupuncture, sir, it's my feeling, and whatever result I have seen, but some of the practices who are there, it is basically a counter irritant type. They stimulate pain at some other point, and that's why the main pain subsides of that knee joint. So that is a slight explanation of that, sir.
Okay. Dr. Mahanti, sir, do you have any Dr. Mahanti is there or? Okay, so actually there are some AOS guidelines. So they are telling there is a low impact exercise, the neuromuscular coordination, loss of weight, there is a reduction of the BMI less than 25, weight insole for redistribution of the load inside the joints, knee joints, and so the NSAIDs, as we have discussed along with some DMO aids. These are the strong recommendation. Whereas no sufficient support is seen as per acupuncture, electrotherapeutic modalities, manual therapies, medial compartment and load sharing devices, and the glucosamine converted. Now, there are some role of this brace locally is already very much highlighted. I'm not going into detail. And then exercises which is very much age specific and symptom specific. And now the controversies is how much and how long duration of the effectiveness exercise should be done for its effectiveness.
So,
Now, orthotics,
Dr.
it is
Pal,
very
just
much
one question. Dr. Pal, just a question.
Yes, please.
How much
Yes,
treadmill?
please.
Most of the people are now indoor in this COVID days. Treadmill should be done or not done? Treadmill walking.
Yeah,
No,
definitely
from-
those who have already started the degeneration should not do the the high impact exercises. This is the
Right.
big time. So once it has started, it will be established. There is a diagnosis of osteoarthritis. There are several diagnostic ways I have highlighted that. So there is to pick up the early features of synovitis, which may be the precursor of osteoarthritis. So once it is diagnosed, every sort of high impact exercise, like even the jumping, walking in a very high speed, these are absolutely contraindicated. Otherwise, that will lead to progression of the
Here I want to tell you something.
Yes,
You see,
please.
the exercise should be specific to the patient. I have told at the beginning.
Yeah.
Age is very important. At what age the patient is coming to you, and regarding the duration of the exercise, you see, in musculoskeletal system, until and unless you increase the load, the tissue is not going to respond. If it is static, like if you do a Brajasana or say Brikshasana they say that one asana should be done at least for 30 seconds minimum. So if you do it less to start with, then go up to 30 seconds. Then it should be increased. Loading should be done, individualized, every not less than 4 to 5 days. So if we're doing a static quadriceps exercise for 5 counts today, lying on the bed and doing the static quadriceps hamstring and the calf muscle exercise, 5 seconds to start with, go to 10 seconds on third day, something like that. Keep on increasing till your muscles tolerate. So increasing load is very, very important. Even at what age you start your exercise? Even at 90 years also, if you start your exercises, it should be increased. Loading should be increased, and then otherwise your muscle is not going to respond. So this is very important. And addition of weights in the exercises is important. But there are some exercises body weight can be utilized. For example, static quadriceps exercise, you can do it lying down on bed or sitting down on the bed. But if you lie down on bed and straight the acute leg raising, then probably you are utilizing the weight of your body to give some pressure on the concerned muscles. I think those things one should be very, very clear when you tell about the patient.
Exactly,
Uh,
exactly.
One more,
The,
sir.
the,
Like
yes.
the dynamic quadriceps exercise, if the patellofemoral joint is slightly involved, should we encourage or not? Dynamic quadriceps, not static, sir.
Dynamic
Dynamic.
exercise. Dynamic exercise is one like cycling. You said
Yes, sir. Yes, sir.
yes, cycling. You see, this is the problem. Say when we had last year or 1 year later, earlier to that, I just forgot it. We had a cycling. Even Anand Joshi came from Mumbai, and there's a regular cycle, and you forget your osteoarthritis. I don't think I disagree with him. A patient who is having an osteoarthritis, you encourage him to do cycling, he's gone case.
Yeah.
If,
So that
if
is
I
that.
suggest him to do like this, he will go to Patna and meet Amulya Singh that Morwa sir is useless. So he
No,
will
no,
help
no.
me out.
No, frankly speaking, whenever there is a saddle joint, patellofemoral has
Yes,
some
yes.
impact, then
Yes,
we should. Personally, I don't advise for this.
Yeah,
you have
yeah,
rightly
never.
Patellofemoral.
mentioned.
Yes,
Abdullah,
sir.
you have rightly mentioned. I'm going to answer you. So,
Yes, sir.
as Dr. Barua has rightly mentioned, sir, during the very painful episode, only the static exercise will sufficient enough.
Yes,
But once the
yes.
pain has subsided, we have to increase the muscle power. So, for that reason, this is the only, that is short arc leg rising exercise. This is the only form of dynamic quadriceps exercise can be advised in osteoarthritis. Short arc leg rising, short arc leg rising. There is not
Right, sir.
not any other dynamic exercise. This short
Right.
arc means patient will just extend it, just dorsiflex it as because dorsiflexion is extremely important for the vastus medialis obliquus, that to maintain it and counter the down and then reduce it not to the ground. Again, it will elevate. This is basically is known as the short arc leg rising exercise. This is the
And
only
I think,
dynamic quadriceps exercise can
yeah.
be advised. Yeah,
And at this point, probably little bit of forceful dorsiflexion of the ankle with
that
the
is a
with the knee straight is very important. This step is
that
very
is the
important. If the ankle is flat, it does not work.
yes, ankle should be dorsiflexed. Unless you dorsiflex it, your vastus medialis obliquus will not work. So that is most important. So this is the most. Another important is the pillets or calinetics. It is especially for the relatively younger woman. So
Young.
the yeah, younger. So for the as is a patient is a 47 years old, I particularly use this technique for this. That is I'm highlighting this. Why pillets? Because that causes the lose the weight, body weight, and I will show you the actual the how much weight has become short of for this patient by this my patient, and that is basically this is the ultimately 2 years conservative treatment, and basically he has lost at least 10 kg body weight, and he has ultimately this to this progress lead much there is mild progression. It's a mild progression, but she is highly satisfactory. His the weight is highly satisfactory. Now he is 49 years old. Now range of motion is increased, that is almost 110 degree. And see the initial period, the little bit the left side, it is much more varus has occurred, but the pain has subsided. This is usually seen the side where the deformity increases, ultimately the nature has taken care of. Ultimately, the pain is absolutely reduced.
Yes,
Now the
yes,
patient,
yes.
that has happened in this case. So pain on the patient has came with the she has came with the pain on the left side. Now after 2 years, now patient has came with some occasional pain on the right side. On the left side, pain is absolutely almost it is not there. He is complaining of pain for walking for long period at only. So that is the story. So this is the case, I think. And is there any comments on this? You can please add some whether anything to be added in this case. Otherwise, I can stop here because lots of cases, lots of points has become highlighted regarding the osteoarthrosis for our audience also, and also regarding the pharmaceutical, for the nutraceuticals and also DMEDs. And as per Dr. Mamullo has highlighted the role of these, and so it is very important. So, so especially in this case, so any panelists do you think anything to be added, so to increase the symptomatic relief?
No, sir, you have
I think
covered it very well. Yes, sir. Yes, sir, Dr. Ranjit, sir. Sir.
no. आप बोलो पहले बोलो.
Nahin. Sir, the way you have handled it, Dr. A.K. Pal, sir, it was really very meticulously planned. And frankly speaking, I learned a lot from Dr. Ranjit's lecture. The way many of the time, just we are not counseling our patients much in a much better way. And many times when the patient goes to a physiotherapist, he or she, the physiotherapist, is not able to explain properly to our patient what a proper exercise has to be done. So we have to sit down with the physiotherapist and tell them what particular exercise this patient has to be done. So it has to be individualized. This is very important. And thank you, Dr. Ranjit, sir. You have highlighted especially some of the tips I've got from you. Thank you, sir.
Thank you.
So thank you. So what we have learned about is that is osteoarthrosis, if we got in a very early stage, so there is a several measures to be taken. There is a multimodal approach it can be taken to prevent or reduce the speed of its progression. We cannot stop it because this is the aging process. But if we take the proper measure, if we detect it properly, if we planned it a better way, so in that case, with the help of our newer nutraceuticals and also the DMID, especially, we are very much thankful to MacLeod's for their unique product, which of this the orcerinc2 and orcerinc which is basically it is we have used this in this case. So it is produce excellent result along with the other physiotherapeutic measures and also the lifestyle modification as reduction of the body weight. This is also worked a lot in this case. So thank you all. I am handing over the mic to Mr. Binod Tagi.
Yes. So now I request my senior general manager, Mr. Ravi Modi, to give some few words. Vote of thanks. Sir, please.
How many participants were there today?
Around 300.
Oh, so nice.
Right. So, good evening, doctors. Thank you very much for this nice discussion. Panel discussion was fantastic, and the cases presentation was fantastic. It is my great pleasure to extend word of thanks to honorable doctors, given their valuable time out of the evening, which is called as a Republic Day evening. Happy Republic Day to all. And the topic is so interesting that we should continue for another 2-4 hours. Then we can continue, or another 1 day, 2 day. This topic is never ending. I extend my sincere thanks to our respected moderator, Dr. A.K. Pal, to take out time from his busy schedule to moderate the events with a discussion on different cases of osteoarthritis. Thank you for initiating the interesting discussion and addressing the possible medical management of osteoarthritis. A special thanks to our respected panelist, Dr. Tanmay Mohanty, for the practical management of osteoarthritis, and special thanks to Dr. Ranjit Borwa for discussing the basics of osteoarthritis, and my sincere thanks to Dr. Amulya Singh for nicely explaining the medical management of osteoarthritis. The medical management in this medical management, our focus was on basically nutraceuticals and other management available for the osteoarthritis. Thank you very much for highlighting the such good medical management. And further, in the last, the panel discussion on different cases was very interesting, and your suggestions, opinions, and expert comments was highly appreciated. I am getting a lot of comments from a lot of audience present today. And it is on behalf of OsteoMatlios, I want to extend thanks to all doctors for the nice participation as audience. At last, I will not miss this opportunity to just offer my solution for the management of osteoarthritis. That three products what we are carrying is the Orcerinc, age old brand is there. It is almost completing 15 years of this launch. Orcerinc, Diacerin is there. Orcerinc GM is there, glucosamine and MSL. And recently we have added, looking into the popularity and looking into the results of undenatured collagen type 2, we have introduced Orcerinc C2. That is a 40 milligram of undenatured collagen, mobili, as well as Boswellia serrata extract and Curcuma longa extract, taking into consideration of the three major factors: inflammation, as well as the synovial fluid management, as well as the management of regeneration of cartilage. So all three things what we have tried to address with this Orser Institute. Thank you very much once again. Thank you for sparing your time and giving us a nice insight over the management of osteoarthritis. Thank you very much for your nice time.
Thank
Thank you,
you.
sir. Thank you.
Thank you all.
Thank you.
Thank you, Dr. Mahant.
Thank you very much.